Good morning, everyone. I'm Dr. Vishwateja from Navodaya Medical College Hospital and Research Center, and I'll be presenting a paper in Sonobuzz 2026. And my paper presentation is on topic of ultrasound and Doppler correlation in splenic infarction from hypoechoic wedges to the absent blood flow patterns. And my guide will be Dr. M. Bharati, HOD and Professor from Navodaya Medical College Hospital and Research Center. And my introduction to my topic is splenic infarction is a relatively uncommon but important vascular emergency of spleen resulting from occlusion of arterial or venous blood supply, often due to embolism, thrombus, or systematic vascular disease. Accurate and timely imaging evaluation plays a key role in diagnosis, management, and follow-up. Role of imaging. While CT is a classical sensitive, ultrasound and Doppler imaging are valuable first-line tools due to their non-invasiveness, real-time capability, and absence of radiation. B-mode ultrasound helps in identifying the parenchymal changes, whereas color Doppler and spectral Doppler assess the blood flow in and around the splenic parenchyma and the vessels. The sonographic appearance in the splenic infarction is we will be seeing hypoechoic lesions and wedge-shaped lesions with the apex directed towards the splenic hilum and absent or significantly diminished flow on Doppler interrogation in the affected region. The methods. In methods, the study design in the study, the retrospective and prospective analysis of the patient presenting with clinical suspicion of splenic infarction referred from the for the abdominal ultrasound and Doppler imaging. The data includes cases from emergency and outpatient settings. Inclusion criteria. We'll be doing with the patients of abdominal pain or pain in the left upper quadrant and ultrasound evidence of any focal splenic lesions and with available Doppler study also. And the ultrasound parameters in B mode scans, we will be evaluating the echo texture, shape, and the size of the lesion. Color and spectral Doppler assess the blood flow within and around the lesion. And contrast enhance the ultrasound for improved perfusion evaluation when it is available. And the data collection will be lesion morphology, echogenicity like hypoechoic, hyperechoic, and isoechoic. Doppler flow changes like present or absent or velocity changes. Radiology findings, ultrasonographic features. B mode ultrasound, we will be seeing the hypoechoic wedge-shaped and peripheral located lesions. With the time, lesions may become hyperechoic as the infarct heals and fibrosis develops. Doppler changes we will be seeing demonstration as loss of blood flow within the infected area. Surrounding splenic area shows a normal vascularity. Absence of arterial and venous flow patterns differentiates the infarction from other vascular conditions. Ultrasound enhanced ultrasound findings. Contrast with contrast, we'll be seeing the non-enhancing areas in all vascular phases, enhancing diagnostic confidence, whereas conventional ultrasound is ambiguous. In contrast enhanced ultrasound, we'll be seeing the dual examination. In normal cases, we'll be after giving the contrast, we'll be seeing after 21 seconds the arterial time with the arterial splenic vessels are seen, and at the time of 42 seconds, we'll be seeing the portal time with the splenic parenchyma becomes homogeneously enhanced, also called as parenchymal time. Next, we have four different images with the splenic infarction. First image, we will be seeing ill-defined peripheral wedge low reflective area on grayscale imaging. On color Doppler, no color uptake is seen in the infected area. And third image, we'll be seeing a post-microbubble contrast media imaging using low mechanical index technique and defines the wedge-shaped non-enhancing infarct with normal enhancement of surrounding splenic parenchyma. Contrast enhanced CT shows the wedge-shaped non-enhancing area of low density in keeping with an infarct. The results, the typical presentation, most patient presents with the left upper quadrant pain or non-specific abdominal discomfort, often with the risk factors such as coagulopathy, atrial fibrillation, or portal hypertension. On B mode ultrasound scan, lesions will be predominantly wedge-shaped and hypoechoic in acute phases. In Doppler, we'll be seeing absent flow conforming with the avascular infarct zones in the majority of the cases. Evaluation of the lesion. Subacute infarcts may gradually become more conspicuous on ultrasound as the hyperechoic changes over time. Chronic infarction may show calcifications and persistent absence of flow on color Doppler. Discussion imaging challenges. Ultrasound has limitations in sensitivity compared to the CT, especially in early stages when isoechoic changes may be subtle. However, Doppler adds a significant value by evaluating the hemodynamic changes, showing absent or diminished flow consistent with the infarction. Comparison with the literature. Literature supports the classical wedge-shaped hypoechoic lesions on ultrasound and absent blood flow in the infected area as diagnostic clues. Contrast-enhanced ultrasound provides a superior delineation of the non-perfused zones, improving diagnostic accuracy. Clinical implications. Prompt identification of the splenic infections can influence the management, guiding further for CT or contrast-enhanced CT, contrast-enhanced CT or ultrasound assessment, and helping differentiate from the mimics such as abscess, hematoma, and neoplasm. Conclusion. Ultrasound combined with the Doppler is a valuable and accessible modality for the early identification of the splenic infection. Key sonographic features include hypoechoic wedge-shaped lesions and on B mode and absent blood flow on the color Doppler as discussed earlier. Contrast-enhanced ultrasound can further refine diagnosis when necessary. Early recognition reduces the diagnostic relay and helps guide appropriate clinical management. And these are the references for my study. Thank you.